Good morning, everyone. So I get the honor of talking about spine at a trauma conference, everyone's favorite subject over here. But seriously, I'm going to make this quick and painless, kind of keep it down to the practical things, and what you need to know, what you don't need to know, and all of the above, and I'll catch us up on schedule, Ted. So I'm going to talk a little bit about the initial assessment, the clinical clearance, imaging interpretation, and then different clearance scenarios. So let's first talk a little bit about instability, just because that's kind of the guiding principle to how we know when we could and cannot clear the C-spine. So basically, instability is the loss of the ability of the spine under physiologic loads to maintain its pattern of displacement. So there is no initial or additional neurologic deficits, no major deformity, and also no incapacitating pain, which becomes very relevant when it comes to clearing the C-spine. So ATLS guidelines of the ACS say that all trauma patients should be presumed to have an unstable spine injury until all aspects of the cervical exam have been adequately studied and an injury excluded. Basically, you don't want to miss these injuries. Better to be safe than sorry. So like everything, you need to get a very thorough H&P, and that includes the mechanism, the anticoagulation status. You need to ask them if they have any numbness, any weakness. Sometimes when you examine a patient and they're like a big muscular person, their weakness may feel strong to you because you haven't gone to the gym enough. Or if it's an elderly person, they may just be a bit deconditioned and their 5s may feel like a 4 for you. You want to make sure and see if there's any midline tenderness, a good thorough exam, and never forget the rectal exam. As one of my colleagues like to say, the only time not to get a rectal exam is if you don't have a finger or the patient doesn't have a rectum. So let's start with this case. You've got a 45-year-old male, fell from skateboard, doesn't have any other injuries. He denies any pain or weakness. His GCS is 15, normal state of mind. He was placed in a collar. The physical exam shows no midline tenderness to palpation, neuro intact, as well as normal rectal tone. I got my finger. We also evaluate the whole ASIA score. We do a thorough exam looking at the different muscle groups, sensory levels, look to see if there are any patterns of deficits, bowel or bladder incontinence. As we know, we grade all of our muscle strengths from a 0 to 5 scale. And this is standard when evaluating a patient for a spinal injury. And so back to our patient. Do we even need to get any imaging in theory? So according to the Nexus criteria, who doesn't need imaging? Someone with a normal level of alertness, no evidence of intoxication, absence of tenderness in the posterior midline, absence of neurologic deficits, and no distracting pain elsewhere. I'll also add an asterisk. If they come in as a level 1 or 2 trauma, it is standard practice to get cervical imaging, whether X-ray or CT. So could we clear the spine? In this case, if the patient's alert with a normal exam, the C-spine could be cleared on a clinical basis with the Nexus criteria being fulfilled and active painless range of motion. What if the Nexus criteria are not met? Or if it's a trauma and we have the imaging, well, we kind of need to understand how to read the imaging and we need to make sure that it's negative. And so basically our imaging modalities of choice are X-rays, CTs, and MRIs. I put a little asterisk with the MRI because that's an as-needed type of exam, but generally speaking, when the trauma comes in, you either need a cervical X-ray, but nowadays, most trauma centers just get a cervical CT. So when looking at your upright X-rays, you want to make sure that you're able to see down to T1. You're looking at the anterior longitudinal line, want to make sure that it's continuous, and that's a line that goes along the anterior aspect of the vertebral bodies. You're assessing alignment, the disc spaces, and the soft tissues. You want to also evaluate the continuity of the posterior longitudinal line, which is the posterior vertebral bodies. You want to check the alignment of the spinous process, make sure that, again, there are no step-offs on imaging, and that the interspinous distance is maintained throughout the length of the cervical spine. You want to also look at the spinal laminar line and make sure that that is continuous and doesn't have any breaks in it. And so in summary, these are your 4 lines that you look on your typical lateral x-rays, and you want to make sure that the facet joints, which are those shingles over there, are actually shingled and not jumped as well. You could see the facet joints on these CTs over here, and you could see how they go down shingled. And it's really important to also take notice to the occipital-atlantocervical spine area and make sure that the occipital condyle sits nicely in C1 and is congruous, and that you don't have any gapping or subluxation in that area. In addition, you want to take a look at the soft tissue shadows. That is especially important in cases where you do not have any injury that extends through the bone, and injuries that are purely soft tissue, or if it's a fracture that is non-displaced. And typically we talk about there being a 6 millimeter soft tissue shadow at C2 and a 2 centimeter soft tissue shadow at C6. And so let's go over a few scenarios over here. So scenario number 1, the alert patient, normal cervical spine exam. The C-spine could be cleared with negative imaging, nexus criteria fulfilled, no midline tenderness to palpation, and painless active range of motion. Scenario 2, you've got this patient who's alert, normal exam, but he has neck pain with either range of motion or palpation and unremarkable x-rays and CT. Those patients, I keep in a collar and reevaluate at a later date. They could have been banged up from the injury, and maybe later at that hospital stay, I'll re-examine them. Or if they are getting discharged, I just follow them up in 2 weeks in the office while keeping them in the collar. Scenario number 3, same alert patient, normal exam, has pain with either range of motion or palpation, negative imaging. However, this person doesn't want to wear a collar, he's not going to be compliant, or whatever reason. You could get an MRI, and if the MRI is negative for any injury, you could take off the collar. Scenario number 4, you've got an unexaminable patient with a negative X-ray and CT, keep them in the collar. However, sometimes, and most commonly, you'll get a call from the ICU. This patient could be on a vent, or the collar could get in the way of care, or maybe the patient has a femur fracture and anesthesia has difficulty intubating them, or whatever the reason, the collar needs to be removed, or people want to remove the collar for patient care issues. You could get an MRI as well, and if that's negative for any injuries, you could also clear the collar. Thank you. Have a wonderful day.